Are we all ready to move on to our lovely next speaker? So I'd like to welcome Professor Emma Crosby, who's going to give us a scintillating update on Lynch syndrome, and that will move us into our molecular pathology section. So Emma, please. I'm short, you might want to raise that. Can I just mention, our sponsor Nicola outside for today's event is here promoting Dermol. If you have a chance to just visit her stand during the course of today, that would be great. Thanks.
Hello everybody, thank you for inviting me to talk to you today about endometrial cancer and Lynch syndrome. I'm Emma Crosby, I'm a Professor of Gynaecology at University of Manchester and MFT. So I'm going to talk to you today about Lynch syndrome, so briefly what it is. Then talking about who we should be testing with endometrial cancer for Lynch syndrome, what the risk of endometrial cancer in Lynch syndrome is, and whether risk-reducing hysterectomy is recommended in people with Lynch syndrome, and finally whether there is any evidence for endometrial cancer surveillance in people with Lynch syndrome. Helps if you point it at the actual machine. So what is Lynch syndrome? My eyesight isn't brilliant. I'm going to try reading it off there. Lynch syndrome is the most common inherited cancer predisposition syndrome. It's thought to affect around 1 in 300 of the population, but only 5% are aware of their diagnosis. And it's caused by an inherited defect affecting one of the 4 mismatch repair genes, which are MLH1, MSH2, MSH6, and PMS2. And this condition is inherited as an autosomal dominant condition, which means that a parent passes it on to approximately half of their children, irrespective of whether they're girls or boys. So Lynch syndrome increases the risk of cancer, typically colorectal cancer, endometrial cancer, ovarian cancer, and a range of other cancers. And these cancers tend to occur at a young age, and a person may have more than one cancer during their lifetime. But importantly, in women, endometrial cancer is often the first cancer diagnosis in a person with Lynch syndrome. And so it offers a really important diagnostic opportunity, because if we can identify Lynch syndrome in a carrier, then we can engage them in risk-reducing interventions that help them to prevent future cancers in themselves and in their at-risk family members. So, for example, they can engage in regular bowel cancer surveillance by colonoscopy. They can take an aspirin, which has been shown to reduce the risk of cancers by about 50% in people with Lynch syndrome. And their family members, who may also be healthy carriers of Lynch syndrome, can be identified and cancers can be prevented in them. And all of these interventions have been shown to save lives in Lynch syndrome. So when we started looking at this about 5 years ago, we noticed that despite similar risks of colorectal and endometrial cancer in Lynch syndrome, there were huge disparities of care. So, for example, for colorectal cancer, there was already universal screening for Lynch syndrome was recommended by NICE. There were established Lynch syndrome testing pathways in place. There were national and international clinical guidelines recommending best care, and there were also evidence-based colorectal surveillance for cancers. But none of these things existed for endometrial cancer. And so we wanted to know what was happening in the UK. We paired up with Lynch Syndrome UK, which is a patient support group charity, and we did a survey across the country to find out what gynecological services were available for people with Lynch syndrome in this country. And we basically found that there was just a huge hodgepodge of different clinical practices according to where you lived. And this essentially was a bit of a postcode lottery, such that some places had no services at all, and other places were offering Lynch syndrome testing for some patients with endometrial cancer, gynecological surveillance, and so on and so forth, but it basically depended on where you lived. There was no consistency whatsoever. And we wanted to do something about that. So we convened the Manchester International Consensus Meeting, where we invited experts from all over the UK, from Europe and from North America to come and talk to us about what we should be doing. So what was the state-of-the-art science in this area? What should we be doing for our gynecological patients with respect to Lynch syndrome? So on the first day, we heard from the experts, and on the second day, we had working groups that we rotated delegates through. And the idea was to try and come up with some kind of guideline for what we should be offering our gynecological cancer patients and our patients with Lynch syndrome at risk of gynecological cancer. And this process really ended up with more questions than it answered, and these broadly fell into two main groups. So for women with endometrial cancer, who should we be testing for Lynch syndrome and how should we be doing that? And for women with Lynch syndrome who hadn't themselves had gynecological cancer, was there anything that we could do to reduce their risk of endometrial cancer? And was there anything that we could recommend in terms of surveillance so that we could pick up early stage disease? So moving on to the first question then, which was about who we should be screening with endometrial cancer for Lynch syndrome. It's not working very well. Am I pointing at the right thing? Okay, press it harder. So first of all, we carried out a systematic review to find out what proportion of endometrial cancers might be caused by Lynch syndrome. And there were a few studies out there. There were about 53, of which there were around 12,000 endometrial cancer cases. And essentially from this process, we were able to show that the proportion of endometrial cancers associated with Lynch syndrome was about 3%, which is exactly the same as the proportion of colorectal cancers associated with Lynch syndrome. But what we also noticed was that the quality of the studies was really poor. Few of the studies had tested all eligible patients. And no studies had compared the different testing strategies, so we didn't know how best to test our endometrial cancer patients for Lynch syndrome. And finally, all the studies have been conducted in a private healthcare setting, which meant that there was real selection bias, because if a person took part in a study and found out they had Lynch syndrome, then that would have an effect on their insurance premium. And so only about 50% of people approached to take part in the study actually agreed to take part. And so we carried out the PETALS study, which was the first UK prospective study that tested all endometrial cancer patients that came through MFT for Lynch syndrome. So we compared all the different testing strategies, so principally screening all endometrial tumours for mismatch repair deficiency by immunohistochemistry and MSI testing. And I'll go on to talk about that in a little bit. We also did reflex MLH1 methylation testing, where that was indicated by these primary tumour triage tests. And then we did definitive germline Lynch syndrome testing on anybody who had a positive tumour triage test, but in addition, anybody who had a particularly strong family history or anybody who was aged under 50 at the time of their cancer diagnosis. We bolted alongside that a microcosting study to find out how much it actually costs to test endometrial cancer patients for Lynch syndrome, and also an acceptability study to find out whether this is actually what people want. And these are the results of the PETALS study. So you can see from this that we had an average endometrial cancer population. So they had an average age of 65, an average BMI of 32. The majority were white European with early stage endometrial cancer, which is broadly in keeping with national statistics. And of these, 88 had positive tumour triage. That means that they either had mismatch repair deficiency by immunohistochemistry or they were MSI high. They had an indicative family history and or they were aged under 50. And of these, there were 135 who went on to have definitive germline Lynch syndrome testing. So anybody who appeared at risk from that initial triage went on to have proper Lynch syndrome testing. And we confirmed that around 3% of endometrial cancers would appear to be associated with Lynch syndrome. And of those 16 Lynch syndrome cases that we picked up, 3 were already aware of their diagnosis, but we picked up 13 new cases of Lynch syndrome. And we published these data in PLOS Medicine. And the really important part of this work is that because we tested everybody using all the different testing strategies, which was the first time this had been done, we were able to show the best way to test our endometrial cancer patients for Lynch syndrome. And if you look at this table, you'll see in the top red box that if we used mismatch repair immunohistochemistry, then we picked up all of our 16 Lynch syndrome cases. But if we had used MSI as the index test, then we would have missed around 7 of the 16 Lynch syndrome cases. So they weren't all MSI high. And that's a little bit different from the case in colorectal cancer, where these two tests are broadly equivalent. And it's due to the different genes that are associated with Lynch syndrome in endometrial cancer compared to colorectal cancer. Furthermore, we showed that if we had used age as a cutoff for who to test, then we would have missed our endometrial cancer patients with Lynch syndrome. So age 50 was just not discriminatory enough. And we even found somebody in their 80s who had Lynch syndrome. And if we had used family history, then that was just useless. I mean, essentially, it didn't help us at all to identify people who were at risk of Lynch syndrome. We also showed that women want to be tested for Lynch syndrome. So over 99% of people approached to take part in this study actually agreed to take part. Only 2 people refused to take part, both of whom had no relatives that could be at risk and who were very elderly and thought that it wouldn't have any implications for themselves or for their family. But what was really interesting is that it seemed to matter when you asked people about Lynch syndrome testing. So if we asked people in the preoperative setting, either on the day of surgery or prior to that, then they were understandably quite anxious about their surgery and found it quite anxiety-provoking to be asked about Lynch syndrome testing. But if we asked them when we saw them back in clinic after their surgery with their results, then they actually really wanted to know whether they might have Lynch syndrome because they were starting to question why they had developed this cancer and are they at risk of future cancers and could this be something their family members are at risk of? So asking them in the post-op setting appeared to be the best time to ask people. And their main motivation for being tested was to protect their family members. How much does it cost to test for Lynch syndrome? So we carried out this microcosting study where essentially we carried out this minuscule moment-by-moment accountability of how much everything costs. So we went around with a clipboard and used a stopwatch. And how much time did it take to consent people for Lynch syndrome testing? How much time did it take to do the actual immunohistochemistry to report the slides and so on? And also looked at the reagents and the wear and tear of the equipment and so on and so forth. So this is the actual costs of testing for Lynch syndrome, and it's about the whole pathway. So this isn't about the patient with Lynch syndrome, this is about the endometrial cancer patient who may or may not end up being diagnosed with Lynch syndrome. And we were able to show that the most clinically effective way that we had found in the PETAL study, which is doing mismatch repair immunohistochemistry, followed by reflex MLH1 methylation testing, was also pretty cheap, so less than £50 per endometrial cancer case. And in addition, we did some cost effectiveness testing because knowing what something costs isn't the same as knowing whether it's cost effective for our NHS. So we teamed up with some academics at the University of Exeter to do a proper cost effectiveness health economics modelling. And we were able to show that the Manchester approach of doing universal testing of all endometrial cancer patients by mismatch repair immunohistochemistry, followed by reflex MLH1 methylation testing, followed by germline Lynch syndrome testing for those at risk, was also cost-effective, costing about versus no testing at all. So essentially, this is something that we would be able to recommend for our NHS patients. And essentially, this is the pathway that our programme of research has shown to be best at picking up our Lynch syndrome cases. So essentially, every endometrial cancer patient, every endometrial tumour should be tested for mismatch repair deficiency by immunohistochemistry. And that will reveal about 75% to be mismatch repair proficient and therefore not deemed to be at risk of Lynch syndrome. The mismatch repair deficient cases remain at risk of Lynch syndrome and need further testing. So if they have loss of MLH1, then we then offer reflex MLH1 methylation testing. And that's because the mismatch repair deficient fraction of our endometrial tumours are actually still most likely to be sporadic tumours, not associated with Lynch syndrome, and we want to reduce the number of women who need germline testing to those who are genuinely at risk. So we want to get rid of, if you like, those who have got sporadic tumours caused by hypermethylation of the promoter region of MLH1, which is the vast majority of cases of mismatch repair deficient endometrial tumours. So if you do that, then you end up with those who are mismatch repair deficient based on loss of MSH2 and or MSH6, and those who've got loss of MLH1 and or PMS2 who are not got hypermethylation of MLH1, and all of these people would be recommended germline Lynch syndrome testing. It's about 10% of all our endometrial cancer patients. And this is the point at which we need to be asking consent for testing. And this is something that we're trying to do at MFT in the gynaecology follow-up appointment. So they've had their surgery. We've already got the results of their mismatch repair deficiency testing. We may well have got the results of their reflex MLH1 methylation testing. And therefore, when they come to see us for their results, we can say, ooh, your tumour looks like you may be at risk of Lynch syndrome. This is what that means. Would you like us to test your blood? And we can send the blood off at that point. Then we'll get a result back, which will enable us to get them seen quicker in clinical genetics than if we just referred everybody, because the vast majority would still not have Lynch syndrome. Remember, only 3% will end up being diagnosed with Lynch syndrome. And of course, if we diagnose Lynch syndrome, then we can enroll that patient in further interventions that can reduce their risk of future cancers, bowel cancer surveillance, aspirin, chemoprevention, and test their family members. So we took all of the data that we had built here in Manchester to NICE, and over an 18-month period, they held a proper evaluation of all the data and the other studies that had been published in this area. And we were really pleased that in October 2020, they released new guidance recommending that all endometrial cancer patients should be offered testing for Lynch syndrome using the Manchester approach. And this really matters for patients. So this is Susan, one of our patient advocates, and she says, I'm so pleased that women diagnosed with womb cancer will now be offered testing for Lynch syndrome and the difference this will make to so many women and their families. And Genevieve Edwards, who's Chief Exec of Bowel Cancer UK, this excellent decision by NICE will undoubtedly save lives from bowel and other cancers by identifying more women at risk through Lynch syndrome. And it also resulted in our team here in Manchester receiving a whole load of regional and national prizes, really recognising that the research that we had done had resulted in clinical impact that would potentially save lives. And of course, knowing that an endometrial tumour is mismatch repair deficient has advantages beyond finding people with Lynch syndrome, because we now know that endometrial cancer is better regarded as being one of 4 molecular subgroups rather than the traditional type 1, type 2 endometrial cancers, because these different types of cancers have a different prognosis and they also respond differently to adjuvant treatment. And so by identifying those that are mismatch repair deficient, you can see from this piece of work that I was involved in as part of the TransPortec consortium, which was built onto the Portec 3 trial, that the mismatch repair deficient endometrial cancers are actually less likely to respond to adjuvant chemotherapy compared to some of the other molecular subgroups of endometrial cancer. And it also identifies upfront a group of tumours who might respond to immunotherapy at relapse. So in the past, what would happen is a patient would relapse and we'd then need to either take a fresh biopsy, which might not always be possible, or find their archival tumour and test it for mismatch repair deficiency to see if they might be eligible for immunotherapy and likely to respond to it. Now, because that is all done up front, we already know ahead of time that if this patient has advanced disease or they do relapse, that they may be able to respond to immunotherapy, because these types of tumours seem to be much more sensitive to immunotherapy than mismatch repair proficient tumours. And that might be a little bit due to the immune response. So the immunotherapy obviously tries to harness the body's natural immune response and to encourage it to recognise the tumour as being a foreign body, if you like, and to mount an effective immune response. And these infiltrating immune cells just need to be primed through immunotherapy to do that job. Okay, so moving on to the last two sections of this talk. That was all about endometrial cancer patients and testing for Lynch syndrome. And now I'm going to talk about people with Lynch syndrome who've not yet had gynecological cancer and what we might be able to offer them. So the first question is, what prevention measures reduce the risk of endometrial cancer and Lynch syndrome? And of course, this is all about understanding individualized risk. So it's not that Lynch syndrome is actually one thing, with everybody having exactly the same risk of different cancers if they've been diagnosed with Lynch syndrome. It actually seems to matter which of those 4 genes is affected, and not only that, but what type of mutation they have in that gene. So it's about a personalized approach, looking at family history and looking at those parameters. And indeed, a person can now go to the prospective Lynch syndrome database, which is an online calculator, and work out their own individualized risk of different cancers according to their age, based on what type of mutation they have, what kind of Lynch syndrome they have, if you like. And this is some work that we did a few years ago that showed exactly this, that depending on the type of mutation you had would really affect the age at which you would be diagnosed with cancer and Lynch syndrome. So really informing at which point we should be offering colonoscopy to our Lynch syndrome patients. So we wanted to know whether or not this was consistent, and it won't surprise you to know that it really isn't. And we offer risk-reducing hysterectomy as a way of reducing risk of endometrial cancer in people with Lynch syndrome after they've completed their families in completely different ways, up and down in this country, and of course across Europe, and perhaps around the world. You'll see that not everybody is being offered risk-reducing hysterectomy if they have all the different types of Lynch syndrome. So those with PMS2 mutations aren't necessarily offered risk-reducing hysterectomy, although they do remain at risk. And also there's some confusion about whether or not to be offering HRT in this setting. So obviously if we're doing risk-reducing hysterectomy, these patients are also at risk of ovarian cancer, and therefore we might arguably want to do a full hysterectomy and removal of the fallopian tubes and ovaries. And then there's the question about whether or not HRT would be recommended in this setting. And of course it is, because it's not like BRCA and ovarian and breast cancer. It is actually that the estrogen can potentially even prevent colorectal cancer. So there's no contraindication to HRT based on Lynch syndrome, and in fact it might also be protective of future colorectal cancers. So it is important that we are personalising our prescription of HRT as well. So we did some further work looking at the timing of risk-reducing hysterectomy. So when is it best to offer this? I mean, should we be offering it to people in their 20s when they say they don't want to have children, or can we wait till they're 60? And so we teamed up again with the prospective Lynch syndrome database, and this had 2,292 female Lynch carriers who we observed in a prospective way over essentially a huge number of years. And so we were able to document the age at which these people developed endometrial and ovarian cancer. But if we concentrate on endometrial cancer, which is the focus of my talk, you can see that in that top red box, the risk of endometrial cancer, and perhaps more importantly, the risk of dying from endometrial cancer in Lynch syndrome, is really not very high up till the age of 40. At maximum, it's 2%, and that's if you have these more pathogenic variants in the mismatch repair genes. But from the age of 40 to 50, you can see that the risk really starts to climb. So it goes up from 2% to around 16% in our MSH2 carriers. But that the risk continues to rise even after 50, out to 70, and no doubt beyond that, suggesting that it's never too late to offer risk-reducing hysterectomy to somebody with Lynch syndrome. And of course, there are other ways of preventing cancers in Lynch syndrome, not just risk-reducing hysterectomy. There's bowel cancer surveillance, which is very well organised in terms of how often that is offered and what we do. There's also aspirin chemoprevention, which, as I said before, reduces the risk of cancers in Lynch syndrome by 50%. And also knowing about Lynch syndrome can affect what treatment somebody has when they have an index cancer in terms of personalising their care. So this is the final part of the talk, and that's talking about gynecological surveillance. So this is healthy carriers of Lynch syndrome who are at risk of endometrial cancer. Is there anything that we can offer them to diagnose their cancer at a precancerous stage or at an early stage, and has that been shown to be of benefit? And the short answer is no. So there is lack of evidence for benefit of gynecological surveillance in Lynch syndrome, and that's mostly because endometrial cancer does present early and has a really good prognosis. I mean, clearly that's slightly different in Lynch syndrome because they are often premenopausal, and therefore it's confusing in terms of the referral pathways. But if they're known to have Lynch syndrome, then looking for abnormalities of bleeding is something that can alert a clinician to possible endometrial cancer. But there is no good evidence that gynecological surveillance improves outcomes. And of course, the tools that we use for investigation of postmenopausal bleeding actually aren't that useful in this population. So transvaginal ultrasound scanning to identify endometrial thickness isn't much use if you're getting natural cyclical variation in endometrial thickness in a normal way, physiological way. And of course, hysteroscopy and endometrial biopsy, it's invasive, it's expensive, people have to come to hospital. They may not like having it done, they may find it really uncomfortable, they might not be able to tolerate it at all. So clearly we need a better screening tool for these patients with Lynch syndrome. And there's actually a really lot of exciting research going on in this space at the moment. This is one of the first studies that was published. This is the PAP-seq study that essentially looked at taking a cervical sample and then interrogating the cells in that cervical sample for genetic mutations that would alert us to the presence of endometrial cancer. This was not looking in Lynch syndrome. This was looking at a population of people with postmenopausal bleeding. But what you can see is that if you took those cells using a cervical sample and then did this genetic analysis, you could actually identify 81% of the endometrial cancers that were there. And if you added in a Teo brush sample, which is essentially a little device that goes into the uterus and scrapes cells from the uterus, then you can increase the sensitivity of endometrial cancer detection to 93%. And so this is a real hot topic, if you like, looking for non-invasive biofluids for endometrial cancer detection. So I've talked about a cervical sample, but obviously that still needs a physician or a clinician and, a speculum examination. So there is an interest in doing even less invasive tests, if you like. So perhaps a vaginal fluid sample collected by swab or by tampon, and maybe even a urine sample could help us to identify those people at risk of endometrial cancer. And this really matters to patients. So we carried out a James Lind Alliance priority setting partnership where we asked the public, clinicians, patients, what the top priorities were for detecting cancer early. And in this process was two nationwide surveys followed by a full day priority setting workshop where questions were received and refined, deduplicated, and then finally ranked. And that whole process resulted in these top 10 that were published in the Lancet Public Health. And you can see what simple, non-invasive, painless, cost-effective and convenient tests can be used to detect cancer early was ranked the top most important priority for people. And also, can effective screening tests be developed for cancers we don't currently screen for was number 7. And so this is some work that we've been doing here in Manchester as well. So we had the hypothesis that the anatomical continuity between the uterus and the lower genital tract could offer the opportunity to detect endometrial cancer in naturally shed endometrial cancer cells. So in other words, does postmenopausal bleeding or abnormal bleeding associated with a cancer actually contain malignant cells that you can pick up in a non-invasive way and interrogate for endometrial cancer? So we wanted to look at this. We looked at Delphi screener samples, which are essentially vaginal fluid samples collected using a little device that goes into the vagina, a bit like a tampon, but it's got fluid in the reservoir. Squirt the reservoir, release the fluid, and then collect it back in the chamber. And also just a simple voided urine that the woman produces at the bathroom. And we spun these samples down and looked at them under the microscope and asked the question, can you see any cancer cells there? And actually you can. So we looked at 100 people with known endometrial cancer and 100 people who were coming through the department with postmenopausal bleeding, pre-diagnosis. And we were able to show that if you took these vaginal fluid samples, you could actually see malignant cells in about 90% of them, just from using this Delphi screener device, and in urine about 70%. And then from the ones who were coming for investigation of abnormal bleeding, we picked up all 4 endometrial cancers using these 2 sampling devices. We also picked up a bladder cancer, an ovarian cancer, actually, a stage 1A ovarian cancer, a cervix cancer, unsurprisingly, and for a very small number of false positives. So in other words, it was pretty good at ruling in cancer and pretty good at ruling out cancer. And this is just some data. We published it in Nature Communications. It's just showing you what the cells look like, really, under the microscope. So that cluster of cells in the middle there, those are the malignant endometrial cancer cells. You could see they look quite different from the normal squamous cells on the rest of that slide. And the panel on the other side just shows you that those cells stained positive for markers of the female genital tract, showing us that they most likely did derive from the endometrial tumour. And so we went on to do a much bigger study where we looked at 2,000 women coming through the department, actually 5 centres in Greater Manchester, with abnormal bleeding. And we collected these 2 samples, the vaginal sample and the urine sample, as they came to the hospital and before they had any of their clinical investigations or diagnostic tests. We spun the cells down onto the microscope slides and we asked the cytologists to look at them before they knew what the cancer outcomes were. And we've got some really exciting preliminary data for that, but I'm not going to present it here and now. Watch this space. But actually, it might be even more interesting if we can develop a panel of protein biomarkers, because that could lend itself to a kind of lateral flow test that could be done point of care, rather than needing cytologists that clearly are extremely skilled, but a dwindling workforce because of changes in the cervical screening program. So we've done some work using mass spectrometry, looking at, vaginal fluids from postmenopausal bleeding women with cancer and without cancer. And we're able to show, as you can see in this very small pilot data, that there's really good discrimination between these 2 populations of cells. So in other words, they really do discriminate between postmenopausal bleeding women who do and do not have endometrial cancer. And ultimately the aim is to develop some kind of endometrial cancer screening tool that a patient could do in the comfort of their own home that's completely painless, and potentially send it to the lab. If the lab is test negative, then they can be reassured they don't need transvaginal scan, hysteroscopy, biopsy. But if the test is positive, then we would invite them in for those tests. And clearly, if we could develop something like that, that would be absolutely incredible for our Lynch syndrome patients. But maybe even a point of care test like a pregnancy test that the patient themselves can read. And this is an area that we're continuing to work on. And that's the rest of my talk. Thank you.
Any questions, or is that the floor pregnancy test for cancer?
Moving that on to early detection of endometrial cancer, but actually for postmenopausal women, we pick it up quite quickly, as we all know. But that's interesting about the ovary. So what about that? Because, as we all know, they present late and lots and lots of difficulty with.
So we really need an ovarian cancer screening tool, and I don't think this is going to be it.
It's not.
So yeah, I mean, we've seen about 60% of ovarian cancers would appear to be picked up with a vaginal fluid sample or a urine sample, which is better than nothing, but maybe not quite good enough.
Obviously for Lynch syndrome, we've got the TAH-BSO after the age of 40 as risk reduction. But we do have a subset of patients who decline that for various reasons or because they're surgically very high risk. Is there anything else that we can offer them, such as, is there a role for a Mirena coil in terms of risk reduction and preventing endometrial cancer in this subset of patients?
That's a really good question. So we think probably Mirena coil does work. Although it's not a hormonally driven tumour, it still requires the endometrium to be proliferating. And clearly, if you've got a Mirena coil which causes complete atrophy of the endometrium, then it's much less likely to proliferate and accumulate mutations that can cause cancer. But there's never been any randomised controlled trial. There was one, actually, that started, but it stopped early because there wasn't equipoise. So neither the patients nor the clinicians were sufficiently in equipoise to be able to be randomised to one or the other, because most of them were like, well, I'll have the Mirena coil then if it might work. But actually it probably does. There are some prospective data that show that progestogens, including the Mirena, combined oral contraceptive pill, as they work for sporadic endometrial cancer, probably work in this setting too. But it's not good enough evidence to say definitively, but certainly is something that I offer.
Great, thank you.
Yeah, it's not a puppy anymore.
Hi, that was a nice presentation. I'm a pathologist. Just would like to know a few things about MSI testing. So we were already doing for colorectal cancers MSI testing, and currently as well, along with MMR, some of the clinicians ask for MSI. I don't understand the difference when you said there is a genetic difference between Lynch in endometrial and Lynch in colorectal. So that is something confusing. And the Americans have come up with a lot of publications where they show that MSI plus testing is better than MMR. So in one of the latest journals also, they show that MSI plus is better than MMR. And the other thing is, going forward, if we need pol-E testing, the tissue is very limited. So we have to first do MMR immunohistochemistry and then send the tissue for pol-E testing. So why not just combine MSI plus poli? So that will save the tissue, because the biopsies, sometimes the material we get is very limited. And on a practical level, sorry, one more question.
You're going to have to remind me them all, though. I mean, they're great questions, but you'll have to go through them one by one.
Sorry about that. The third question is on a practical... Okay. So on a practical level, while doing MMR immunohistochemistry, we found that it adds a lot of time to the entire process, because we don't stain the slides in-house. We have to cut the sections in the lab. The secretaries have to pack them. They are sent by courier. They come back, and then we report them. So this is delaying the entire process. So I think going forward, maybe we need to support MSI testing, and maybe it will be proved that MSI will turn out to be better than MMR. I don't know.
Great. Okay, let me try and remember them all and start at the beginning. So the thing about it is that MSH6 quite often causes endometrial cancer and not so much colorectal cancer. They're still at risk of colorectal cancer, but the absolute risk is less. And MSH6 endometrial cancers are not MSI high. So if we don't use mismatch repair deficiency and find that they're MSH6 deficient, then we will miss those people. So that's the first thing. They just aren't. And some of the MSH2 also not MSI high. This is different from colorectal cancer, where most of them are MLH1, MSH2 as well, but most of them are MSI high. So there is a difference in the endometrial cancers and the colorectal cancers based on the people who are developing those tumours. The second one, MSI plus. Is that the second question? That is being tested throughout the country, and actually it does look a lot better than traditional MSI testing. We put the PETALS slides, all of those 500 tumours, through the MSI plus tumour testing assay. It was able to show that the MSI through MSI plus is slightly better, 5% better in sensitivity, but it's still missing between 15 and 20% of the endometrial tumours associated with Lynch syndrome. It's better, but not as good. The third one about the pathways, yes, it's about local pathways, and it is very difficult. If you don't have access to MMR testing on site, I can understand that it increases the length of the pathway, and that is something that the National Lynch Syndrome Project is trying to support and trying to help, because it very much is recommending MMR testing as the first off. So sometimes MMR testing is equivocal, sometimes it needs to be repeated, sometimes it doesn't work, and those are the cases where MSI testing could be useful. Agree with you about the amount of tissue. It's going to be difficult to know what best to do, but I guess, it is difficult to know, but we do also usually have a hysterectomy specimen, so it's about knowing what do we need to know at the biopsy in order to best inform any surgical difference or any treatment in the adjuvant setting, and therefore how should we prioritise those tests. But yes, no, I hear what you're saying, there's limited tissue. If we could do one genetic test, wouldn't that be better? But the MSI Plus national implementation study should help us know that better.
Thank you.
Thank you.
Thank you very much.
Thanks.
I believe we have a double act now. We have Richard Edmondson and Helene Schlecht who are going to present together a section on poly and somatic testing.
Thank you. So, Richard Edmondson. I'm Professor of Gynaecology as well, similarly based at the University of Manchester and MFT, for those that don't know me. And the astute amongst you will have noticed that I'm down to talk twice today. So in the first bit now, I'm going to spend about 20 minutes, hopefully pivoting from that last question and that last area into the current landscape of what we're doing in terms of molecular classification, which I'll explain. And that should lead on to, very nicely, Helene taking over to talk about some of the practicalities of testing, which will address some of the questions that we've just had. This afternoon, I'm going to take a slightly different tack and go back a little bit and think about genomics in terms of cancer diagnosis and how we're moving forward, predominantly using the 100,000 Genome Project as an example. So this afternoon will be a little bit more educational. We'll go back a little bit and talk about what genetics all is. But what I really want to focus on for the next 20 minutes is the current molecular classification that we're using. And I'm really trying to present the national landscape here. This is not just work we've done in Manchester. This is predominantly the national picture. So you're right, Emma, you have to press this hard, don't you? Those are my disclosures if you're interested. Okay, so first of all, let's ask the question, why do we need to classify cancers at all? So classification, often called the process of lumping and splitting, is where we take bunches of tumours and we categorise them into different groups. So we put some over there and some over there. And the rationale for doing that really is to try and find new ways of grouping cancers that mean we can improve treatment outcomes. So I think it's really important when we're thinking about classification, it has to have a purpose. And so in many ways, I think the purposes could be summarised as prognosis, defining groups that do better or worse than other groups. And I think that's very useful for clinicians and patients when we're trying to explain to a patient their likely outcome. But really what we're striving for is prediction. In other words, this group will do better if they have treatment X, and this group will do better if they have treatment Y. So we're constantly looking to classify tumours in that way. And I would argue we're not really in the business of trying to classify tumours just for academic interest. Sometimes it's very great, you can split things in lots of different ways, but if it's just for academic interest, it's not really going to improve treatment outcome. So when we're talking about classification, we're really trying to look at how can we group our patients that will make the best difference for them. So if we start with ovarian cancer, traditionally we've actually had a pretty good classification system. This is a version of the WHO classification that we've used for years. And this is based on morphology. In other words, what does the tumour look like under the microscope to the pathologist, either just with the naked eye looking at it or the addition of immunohistochemistry. And as you will all be aware, we split ovarian cancer into the three major groups: germ cell, sex cord stromal, and then the biggest group, epithelial, which subdivides into the relatively rare mucinous cancers, high-grade serous, which is the commonest, low-grade serous, which actually it turns out is nothing to do with high-grade serous and is a completely different disease, and then endometrioid cancers. And to be honest, I tend to lump clear cell in there because it's kind of a variation probably of endometrioid. So that sort of four-way classification. So that's worked fairly well, and it does work well for prognosis. It actually works quite well for prediction as well. We know chemotherapy response rates are different between those different groups. But really what we've been trying to do, I guess for the last 10 years or so, is to work on that high-grade serous group and see if we can split that further and make more meaningful digressions. Now, the high-grade serous tumours are all driven by a mutation in P53, so I think that's fairly clear now, that those tumours have a mutated P53 gene, and that's one of the major drivers of the cancer. That abnormality is what allows the cancer cell to grow and divide. But it's also fairly clear that there are secondary drivers. There are other mutations in other genes which are making those cancers work. And this is a pie chart that a group of us developed about 10 years ago now, which tries to explain those secondary drivers. So all of these cancers have a mutation in P53, But then if we look at high-grade serous, a proportion have these other genes being mutated. And you'll see our friends in there, BRCA1 and BRCA2, and then there's a whole bunch of other genes as well. And what became apparent is that you can split that group in half. And you can split it into a group here, represented on the right-hand side of this pie chart, which we call homologous recombination defective, and a group on the left-hand side, which we call homologous recombination competent. What that refers to is just a mechanism by which cells repair their DNA. So we all have lots of DNA damage occurring in all of our cells all of the time. And for all of us sitting in this room, we're busy repairing that as we sit here. But it's clear that some cancers have a defect in one of those processes called homologous recombination. And in high-grade serous cancer, it's roughly 50% homologous recombination defective, 50% homologous recombination competent. If you want to know what that looks like, this is some stuff we did in our lab, and you can see these red cells at the bottom are ovarian cancer cells taken from patients and then grown in a plastic environment, a plastic dish. On the left-hand side, the red represents DNA damage. We've induced DNA damage. We've irradiated these cells to damage them. And then the little green dots show where it's being repaired. That's a homologous recombination competent cell. On the right-hand side, those are HR defective. You can see there are no green dots. Those cells are unable to repair that pathway. Okay, at this point you're beginning to say, this is all academic now. What does this really matter? Well, it really does matter because we've now got very, very good clinical data that show those homologous recombination defective tumours, the ones on the right-hand side, respond really well to a PARP inhibitor, and patients who are on a PARP inhibitor in that group seem to do much, much better than if they don't receive a PARP inhibitor, whereas the group on the left-hand side, homologous recombination competent, get virtually no benefit from a PARP inhibitor in that setting. So here's a useful stratification, classification that we've made of high-grade serous and split them into those two groups. So if we can determine which ones those are, we can now determine which their treatment plan they should have. So that's led to the pathway that we currently have in place now, the tumor BRCA pathway, which for ovarian cancer patient allows us to sample tumours, because this test, remember, has to be done on the tumour. We're not interested in the blood, we're not interested in, at this stage, germline and familial patterns. We're just interested in what the tumour is doing. So we can now offer HRD testing, homologous recombination defectiveness testing, in our patients, and you'll see we've got 3 stars on that pathway, so 3 points at which we can sample them. So some of our patients with ovarian cancer will be going for primary surgery, so clearly we get tissue at that point, that can go for testing. For those patients who are going for neoadjuvant chemotherapy and interval debulking surgery, we have 2 points that potentially we can get tissue. One is the image-guided biopsy that allows us to get the original diagnosis. The second is when those patients come through for interval debulking surgery. Now, the top pathway is actually fairly straightforward. It's the bottom pathway which provides the challenges. Firstly, because as we were sort of just talking about a minute ago, some of those patients who have the image-guided biopsy will only have small amounts of tissue, and all the cancer tissue is used up to make the diagnosis, and there isn't enough left for the HRD testing. The second challenge is that sometimes patients don't end up with interval debulking surgery, particularly if they progress on their initial chemotherapy, they don't get surgery. That's the sort of bad news. The good news is some patients who do have surgery have had such a good response to the chemotherapy, there's no tumour left. So there isn't anything to test at that point. And we get sort of equally frustrated by the chemotherapy being almost too good. So by the time we operate, there's nothing left to test. So it's critically important those patients at the bottom have both stabs at getting a tissue diagnosis and an HRD test. So wherever there is tissue at that needle core, let's get that for HRD testing, because we know not all of them will make it to surgery. But for those who we can't do it, then at least let's give it a go at the IDS pathway. Where are we going? Well, the HRD test at the moment is a proprietary test. So it's provided by a company called Myriad Genetics in the States. Some of you might remember Myriad from the early 2000s. They actually tried to patent a gene. They're quite an aggressive company, it's fair to say. They tried and failed to patent a gene, but they provide this test, which is pretty expensive. It's not actually that good because it's based on some surrogate markers of HRD, and I think we could probably do a lot better. And what we'd like to replace that with is a test based on whole genome sequencing, which I'll talk about this afternoon and try and explain what the rationale for that is. But if we can do that, it would actually be non-proprietary and therefore much more available and probably give us much better information. So with ovary, we've got HRD in place because of that classification, and that seems to work pretty well. Okay, so let's then focus on endometrial, and this is where I sort of segue a little bit with what Emma's just said, because she's hinted at some of these some of these issues. So in endometrial cancer, we didn't really have a very good classification, it's fair to say. For years, we've classified them into type 1s and type 2s, but to some extent, it didn't really make a lot of difference. It wasn't that useful, and we didn't really do it in clinical practice, particularly the type 2 cancers. That was everything. There was a hodgepodge in there, and it didn't work very well. And then a project came along called the TCGA, which stands for the Cancer Genome Atlas. And TCGA was an American attempt to study cancers in great depth. And they studied tumours across the board, but I think it was 350 or something endometrial cancers that went into the TCGA analysis, and they studied them by studying the genetic changes that occur in the cancers. And what TCGA showed was what's on the right-hand side of this screen. So every vertical line here is a different cancer, and they've been arrayed to show the changes in their genome, the changes in the chromosomes. And again, I'll go into this in a bit more detail this afternoon. And I think even with the naked eye, you can pick out at least 3 groups there. The tumours on the left, where there are virtually no changes, the tumours on the right, where there are loads of changes, and then in the middle, it all is a bit of a sort of halfway house, but there are sort of 2 subgroups in there. So they came out with this idea that there were 4 subgroups of endometrial cancer based on the genetic changes occurring in the cell. And they called them these 4 names, which I'm not going to go into because I'm going to change the names in just a second. That finding has now been validated lots of times. It was particularly validated by the Transportec group, which Emma and I are both part of, which was a European initiative study and did include some Manchester cancer cases in that, so Manchester featured there. And then by the British Columbia group at the bottom, who validated it as well. So this is a very robust finding that these 4 groups exist. So I just want to describe those 4 groups, and I'm using colours intentionally here. So the first group is the P53 mutant group. So this is a group of tumours where the P53 gene is mutated. Remember, that's what I said all high-grade serous cancer has a mutation of. And in many ways, these tumours are very ovarian-like. And the more we study, the more we think there's more and more in common between P53 mutant endometrial cancer and the P53-driven high-grade serous ovarian cancer. And they have a generally quite high response to chemotherapy, but overall a poor prognosis. Then there's the mismatch repair defective group, which you just heard all about, because all of the Lynch syndrome fits into this group. But remember, it's not just Lynch in here. There's another group of tumours who have defects in that mismatch repair defective pathway. That's one of those other DNA damage pathways, as opposed to homologous recombination. They have a mutated phenotype. That means they produce lots of different proteins, and those proteins sit on the outside of the cell, and that's what makes them particularly attractive for immunotherapy, because they're often flagged up by the immune system and can be targeted by that. Then there's a third group in orange, which we called no specific molecular profile, NSMP, which is just kind of the bit of a hodgepodge of everything that doesn't fit into one of the other 3 groups. So if you're not in one of those 3 groups, you're NSMP. It may well be that there's more than one subgroup in here, and there may be further classification we can take, but this is a kind of hodgepodge group at the moment. And then the last group, which in many ways is the most interesting, is the POLE group. Now, these tumours have a mutation in the polymerase epsilon gene, which we'll talk about in just a second. And that leads to this ultra-mutated phenotype. So they have a very different appearance molecularly from the other tumours. But what's really interesting is that if you just use morphology, in other words, what they look like down the microscope, they will often appear really quite high grade, and you would give them a poor prognosis. But actually, they do extraordinarily well. And very, very few of these patients actually relapse, and their overall prognosis is really good. So they're a tumour that looks bad, but actually behaves really well. So a really interesting group. How do these 3 groups behave? Well, this is the work that we did in the Transportec Consortium, and there are various other studies that show exactly the same thing, basically showing that tumours that have that POLE mutation do extremely well. The mismatch repair group does next best, then the NSMP, and the P53 group does worse. So we've certainly got a classification here which is robust and fits the first of those criteria that I said at the beginning, that it really does define prognosis. But the question is, does it help us to actually improve treatment for patients? And that's the bit that we haven't tested yet, but we are testing at the moment, again, as part of an international project, kind of led by the Transportec Consortium, but it's now morphed into something called the Rainbow Trial. And the Rainbow Trial has 4 arms. So patients will go into the Rainbow Trial, they'll have this molecular profile done, and they'll be assigned to one of those 4 groups. And then each of those groups will be treated differently to see whether different treatments work best in each group. So the P53 group, in red, will have the addition of olaparib added. The green group, the MMRD group, will have an immunotherapy added. The orange group will have a hormonal therapy added. And then the POLE group, because they do so well, that'll be a registry trial where we'll just look and see what happens if we actually remove all adjuvant treatment from that group and see if that's successful. You can now begin to see why I used the colours, and we're trying to stick to the same sort of colour scheme as we go through, and why it's called the rainbow trial. So just a couple of practical things. How do we actually test for all of these 4 groups, and in what order should we test, and how do we deal with results that come back maybe showing 2 simultaneous outcomes? So this is the PROMISE classification on the left-hand side that was initially put forward by the British Columbia Group, and in many ways has now been validated by Charling-Boss in Leiden and his team as the best way to test. So the way to think about this is you take a cancer, and it doesn't matter what order you actually do these tests, but when you're trying to work out the outcome, think about the POLE first. If they have a mutation in POLE, then they're in the POLE group. If they haven't got a mutation in POLE, then do your MSI test or MMRD test and work out whether they're mismatch repair defective. If they're mismatch repair defective, they're in that group. If both of those tests are negative, then think about the P53, and if they're in the P53 mutant group, that's fine, they're in red, and if you've exhausted all your tests, then they drop into the orange or copy number low or NSMP group, whichever terminology you want to call it. And that seems to be a really good way of working, and that's the way we should be doing now in the MDTs. And we've certainly seen a couple of cases recently where we've had a P53 mutation and a POLE mutation. How do you override that? POLE overrides P53, okay? So, to summarise what I wanted to say, I think molecular testing is now standard clinical practice in both ovarian and endometrial cancers. And this is now becoming an integral part of our work and exactly the way we all need to be working within the MDTs. So it's not just something highfalutin and complex over there that we don't need to worry about. This is now mainstream and exactly an integral part of our daily practice. So the terminology that we use and being able to use these classifications is really important. It is beginning to define our adjuvant treatment strategies, particularly, for instance, in ovary where we've got PARP inhibitors or not, and I think it will define our adjuvant strategies in endometrial cancer. We've got a key challenge ahead of us to try and develop better tissue collection pathways, because not all patients are getting tested because there isn't enough material, the material's in the wrong place, or so on. And we need to work as a network to try and improve that across our whole pathway, so all patients who are eligible can get that testing. So at that point, I'm going to stop, and I'm going to pass on to Lane, who's going to talk a lot more about the sort of practicalities of testing and the test directory and fit that in. So thank you very much. I'll sit down.
Okay, thank you for inviting me here to speak today. I'm a clinical scientist. I work in the genomics laboratory at St Mary's Hospital in Manchester, and I'm going to talk about the genomic testing and how we approach genomic analysis of the gynecological tumours in the genomics laboratory. As you've heard from the last 2 talks, genomics is really integral to tumour testing now, and this has really expanded over the last few years. There's so much more that can be done. We're doing more and more genomic analysis and using it more and more to define tumours and to help with treatment options. This has kind of really evolved over the last few years, potentially the last 5 years, and came partly from the 100,000 Genome Project, which I think we're going to hear more about later. We've reprocured genomic testing across England and have developed the Genomic Laboratory Hub services. These are centralised laboratories providing genomic analysis to the whole of England. They've also developed a national test directory to define which tests are available for which patients to help with the quality of testing across the country. And alongside the laboratory and the genomic laboratory testing, they've developed the National Genomic Medicine Service to develop the support network around the genomic testing as well. So these are the laboratory hubs. So the genomic laboratory hubs, the country was divided up into 7 main regions. You can see us there in the northwest, and the 3 main cancer alliances are all served by the Northwest Genomic Laboratory Hub. And this is a screenshot of our National Test Directory website. So there are 2 test directories. There's one that's focused on rare disease and inherited disorders, and then there's a National Test Directory for cancer, and this is about testing tumours. And there's lists, and I'll just go into bit more detail. So this is an excerpt, it's quite small, hard to read, not the prettiest document available, but this is the list of all the tumour testing that's available on the National Test Directory, and this is all centrally funded. So there's no funding issues around this to help ensure that patients get full equitable access to this testing. This section focuses on the gynaecology tumours. So just to zoom in, we've got ovarian cancer. We've heard a little bit about BRCA1 and BRCA2 testing, and more recently the HRD testing that can be done, and the importance of that in ovarian tumours. There's also this NTRK fusion, which is a tumour agnostic treatment, so that's available for all tumour types, and also whole genome sequencing, which is available for high-grade serous ovarian tumours. Endometrial cancer is also on there. We've got this NTRK, as I say, that's available for all tumours. But then we've also got the MLH1 promoter hypermethylation, as we heard about in the Lynch syndrome pathway. We've got tumour testing for these MMR genes, which is an important test once you've gone through the Lynch syndrome pathway and haven't been able to find a germline MMR defect, then it's potentially useful to actually look in the tumour and see if you can find an MMR defect that isn't inherited but is still driving that tumour, and it helps give you that risk of whether it's in an inherited form or not. And then the poly that we've just heard about is also available for endometrial to help with that classification. So a bit more information about how we actually do the testing and some of the challenges we have with the genomics in the lab. So the majority of tumour material available is formalin fixed. The formalin fixation is really important for the histopathology diagnosis, and it stores the material really well. We've got blocks going back years, and we're able to access that material. However, it's not ideal for genomics. The formalin fixation cross-links with the DNA, and then to extract that DNA from that material, you have to break that cross-links, which unfortunately does damage the DNA. So we are left with fragmented DNA of low amounts and quantities and quality. However, there are things we can do, and certainly more recently, formalin procedures have been kind of modified to help and support genomic analysis downstream. So the majority of our standard of care testing is done on formalin fixed material, and it's all optimized to work on that material. I'm not going to discuss whole genome sequencing in detail today, which is unfortunately a slightly different approach. Whole genome sequencing is even more challenging and currently can only be done on fresh tissue. There's no option for doing whole genome sequencing on formalin fixed material currently. So we extract our material, our DNA, and then we've got a whole range of options of how to test. We've got a variety of machines and sequencing assays and different ways of looking at that genomic material to determine what's there and how to classify those tumours. How do we decide which detection method to use? So it's often a balance. It's a balance between how big is the area you want to look at? Do you want to look at the whole of BRCA1 and BRCA2? Do you want to look at the whole genome? Do you want to look at lots and lots of genes? Or do you just want to look at one really, really specific change? And then what's that balance with how sensitive do your test need to go? We're looking often for tumour cells in a high background of normal cells. So we're looking at already a small proportion of the material is actually from the tumour. And then within those tumours themselves, not all those cells will have the changes we're looking for. Often these genomic changes we're looking for are really, really low level. So we need incredibly sensitive tests to do this. And there's often a bit of a trade-off. The more sensitive it is, the more specific it's going to be and only pick up 1 or 2 mutations. And then if you want to look at lots and lots of different genes, you're going to lose some sensitivity. I'm just going to cover a couple of those tests in a bit more detail. So the first one is what we refer to as a pyrosequencing assay. This is a really nice sensitive assay, but will only look at small regions. And it's been developed to do this hypermethylation test that we were just talking about in Lynch syndrome. So the promoter of the MLH1 gene is known to have these regions that can be hypermethylated. And when they are hypermethylated, you get the loss of the MLH1 protein and function. And we're able to determine and distinguish how hypermethylated that promoter is, because the hypermethylation causes sequencing changes. And then we can detect those sequencing changes. and we can check at what level they're at. So we can look at all the cells in that tumour and say how many of them have got this hypermethylation pattern, and therefore is it likely that that's causing that loss of MLH1 that you've seen on IHC or not. And that's it's a really quick, easy test and really useful in the screen with the IHC as an IHC follow-up to pick up those samples where this hypermethylation is causing the loss of MLH1 and therefore it's just more likely to be a sporadic tumour, or whether there's something else causing the MLH1 loss. And then we go on and look at further germline screening for the MLH1 and other genes. The other test, and I suppose this is kind of our main test now, our bread and butter of genomic testing, and that's the next generation sequencing analysis. This enables us to look at all the genes, as many as we want, as few as we want, in a really efficient way. And it allows us to look at more than just hotspots. We can look at broad genes and coverage. It allows us to look at different types of mutations. We can look at the small changes, we can look at gene fusions, and we can also look at copy number changes. And this single test can cover a huge range of those genomic tests that I said were available. We can look at the NTRK fusions, we can look at your poly, we can look at your mismatch repair genes and your BRCA genes all with one test. So the basic principles of next generation sequences is we'll take our starting material, and that might be DNA, it might be RNA if we're looking for fusions, and we'll enrich it for the regions of interest. And that enrichment, again, can be as small or big as you want. You can just do a few genes, or you can do a larger number of genes, or you can do a whole genome. When you're doing whole genome, it's a little bit more challenging. You need much higher quality DNA. Currently, the approach we use in the Genomics Laboratory in Manchester is we have about 200 cancer genes, and we'll enrich for all of them. We then add little barcodes to those pieces of DNA, and that allows us to put all that DNA together from multiple different patients, sequence it in a really efficient, high throughput way on some of these really big sequencing machines that are now available, and then pull down all those different patients' material and work out which changes each patient has. And so the key to all of this is the design, that enrichment process. What are we going to pull down? What are we going to take out of the DNA and sequence and look at? And as I said, this varies from 200 genes, which is what we have a nice balance of. It gives us a huge range of genes that we can look at. We might not analyse all those genes, but we've got all that data there. But that's doable on the formalin-fixed material that we get. And it generally works very well on quite low amounts of material. Whereas if you wanted to do a whole genome, you'd need much higher amounts of DNA there. This is just some sequencing data to show you that whilst we're looking at lots and lots of different genes and they're all going into the same assay, they don't always work the same. They don't react the same. You don't get the same level of data back. So this is a nice coverage of our BRCA2 gene. So this is a small region of the BRCA2 gene, and the grey kind of histobars at the top show you how much sequencing data is coming from those regions, and the blue regions are the important regions of BRCA2. And we get, with this design and the approach we do and the sequencing and the reaction that happens, you get really nice sequencing data. We get lots and lots of information for that region of BRCA. We can then read that and we can identify changes. It's a bit small to notice, but there is a blue bar, a blue and red bar on the lower picture, and that's showing a change. That's a change that's specific to that tumour, and that could be driving that tumour. This is poly. Poly is a different gene altogether. And what we find with poly is, even though we do exactly the same process, it doesn't work as well. The sequencing context, that underlying information that's under there, just the sequencing doesn't work as well. And we can, as I say, do exactly the same with BRCA, but we won't get as much information back. And this just makes it slightly more challenging when they're doing the analysis. And it might not be quite as sensitive a test because we're not getting quite as much information back. And we have to balance these things in the lab to ensure we're getting as much useful information for the genes that are important for the different tumour types. Just a brief mention about fusions. So I've mentioned that we can detect fusions in exactly the same way using next generation sequencing. We start with RNA because we're looking at two different genes that are fused together and they produce a different, when we look at RNA, we can actually see that they are fusing, creating that transcript, rather than just looking at the raw DNA, which doesn't always give you as much information. So this is where you get two chromosomes and you get a rearrangement and you get two different genes which actually now sit next to each other, and often one half of the gene is activating this other gene and leading to this the driving of the tumours with these oncogenic fusions. And this is an example of the NTRK fusion, which is potentially in a tumour cell, but is targetable by with one of the new targeted treatment drugs and licensed on the NHS. So is really important to look for, as well as all our other markers. And again, this is just some detailed genomic analysis where you can see all those bases, and when we line them up, we can see we've got two genes next to each other which shouldn't be, and that's how we determine whether it's a fusion. So what do we do with all this information? This sequencing is giving us huge amounts of data, and we need to determine what's useful. So we'll look for all those changes, and then we do a process of what we class as variant classification. We take those changes and we look at them, of whether they're causing no effect to the protein, and they're in everybody, and those are our green ones at the bottom, they're not going to have any impact. At the top, we've got our red ones. These are ones where we predict those changes with over 90% certainty that they are causing an effect. They are either activating that protein, they are stopping that protein working. And in a tumour cell, we can predict what that would be doing and if that is driving the tumorigenesis in the cell. We do have this big group in the middle, unfortunately, and they're the ones where evidence is just doesn't push us either way, and they are very difficult to work with, but it's important to use as much evidence as possible and predict what these changes are doing. We've talked about poly. So, and again, the difference is when I'm looking at a BRCA1 or BRCA2 gene, we need to look at the whole gene. There could be a change absolutely anywhere in that gene which is causing that BRCA protein to be disrupted and that loss of function. Whereas poly is a slightly different gene. There's actually only a small region of poly where changes cause that poly phenotype we see in that poly classification in endometrial carcinomas. And actually 11 key mutations have been called out in the poly guidelines, in the gynecological endometrial classification guidelines. And those are the most common. Those are the main ones where we know if you have this change, it's a poly classified tumour. So we target our analysis. We only have to look at these changes rather than looking at the whole of the poly gene. And finally, I just wanted to touch on homologous recombination deficiency and how we detect that in the laboratory. This, again, is a slightly different process. This looks at the whole genome. We're not looking at genes now. Yes, we've got BRCA1 and BRCA2, which are very, very important, but we can look more globally. We can look at global changes that are known to be associated with homologous recombination deficiency. You see across the genome, not just in the genes, but all over, you see different hallmarks, and those are known to be associated with homologous recombination deficiency. And these assays, you mentioned the current one where that do the majority of the homologous recombination deficiency testing is Myriad. They look for all of these patterns across. They use a next generation sequencing approach and look for these patterns. You can do a similar approach with whole genome sequencing. You've got that data there. It's about picking up those patterns. And we're also developing other assays in the laboratory, similar to the Myriad, where we're not doing whole genome sequencing, so we'll be able to use the FFP material, but we won't have to send them away to Myriad. We'll be able to do them internally in the laboratory. They're all looking at a similar thing. They're looking for these genomics patterns within that genome. So thank you for listening. There's just a run through of all the different genomic analysis we do.
Thank you very much. That's incredibly academic. Thank you, you understood that. Thankfully, she's got a job. We don't all need to do that. Does anybody have any questions on trying to make a very complex but massively important area? Ravi has got loads of questions. Thank you.
Thanks a lot. The cost for doing the test, for example, if you had to use NGS for poly testing and if we add MSI to that, will it usually vary or it will be the same?
So currently, they are two different tests. MSI, the current MSI test that we have, which we know is not great on endometrial cancers, but is actually a really cheap test, but it's very different to the poly next generation sequencing assay. So they are two different ones. The MSI Plus assay, which is being looked at and is a national program and is being used in our laboratory as well, uses the next generation sequencing technology. It's still a different one to the poly, and you can't do them both together, but there is definitely potential that one day we'll be able to do poly and MSI in the same assay. It's coming,
Thank you.
we think.
Any other questions or comments? I have a couple, if I may, and this one's directed at Richard. You mentioned about the biopsy size, and Ravi, you mentioned this also, especially if we're going to talk about homologous recombinant deficiency testing. And in the group of patients where you're saying they're going for neoadjuvant treatments, where they're biopsy, usually a mentum, prior to starting treatment, then interval debulking, is there a size limit you would like to ask our radiologist to provide you with to get it?
I'm going to flip that back to Lenny, because you'll be able to tell us how much tissue you need, but I think the key point from our perspective is we need to start talking to those radiologists, and actually they're quite a difficult group for us to find, so I'm really intrigued. Sorry. Yeah, the group of people who do these image-guided biopsies, particularly in the units, are a group that are not necessarily known to us. We know the reporting radiologists, but we don't necessarily know the interventional radiologists. And it's a message I'd really like to get out there that they do need to take enough tissue, even if that means taking another pass. So they'll often take 2 or 3 passes of the tumour, and we might need to start increasing that so that there is sufficient tissue. I can't remember exactly how much you need for HRD testing, but...
So if you're looking at fresh tissue, which allows you to do whole genome sequencing, there is a minimum, I can't remember the exact sizing, but there's a minimum amount of tissue that they recommend you take. When you're looking at the HRD test, it's really difficult to put an actual size on there. You need a certain number of tumour cells, and because of the quality changes and varies between the sections, it's incredibly difficult to put an actual size on that tissue. We can work with anything above 100 cells, which is really, really small, but obviously it's impacted by that quality. We can tell you how many sections, but again, it depends how much tumour is in that section.
It's something we are auditing across the whole of GM. I don't have the figures yet, but we will have them about how many patients have had HRD testing and how many patients have missed it at various points. So it's data we will come back with. Yeah.
And will that pull together size of biopsy?
Yes,
because I
yes,
think we need some guidance.
Yeah.
I think we did something similar in Bolton of guiding for cytology, a minimum amount of acidic fluid to improve our capture. And I think would probably be helpful for this as well. And one other question I wanted to ask about, again, the patients going for the neoadjuvant treatment, and you're talking about them being maybe appropriate for PARP.
Yep.
If you get that diagnosis on the pre-neoadjuvant biopsy, would you start PARP then?
No, so PARP inhibitors only kick in at the completion of standard chemotherapy. Okay. So all our patients with advanced ovarian cancer are essentially getting 6 cycles of carboplatin and Taxol, either 6 lots post-surgery or 3, then surgery, then 3. PARP inhibitors just kick in at that maintenance stage of coming in at the end, which is good for us because that means we've got the whole time of that chemotherapy to get all of this diagnostic work done. So we often talk about, diagnostic turnaround times and everything has to be done in 2 weeks. Actually, this is one that doesn't need to be done in 2 weeks. It needs to be done over up to 3 months sometimes if you're using that surgical sample. So there is a little bit of time on our side here and time to consolidate all of that and then plan their commencement of PARP inhibitor at that point. Yeah.
Thank you. Siobhan, good. Thank you.
So I know we're testing this in the Rainbow study, but we are already using the poly in the MDTs to make decisions. So should we therefore say that the POLI, based on the flow chart that we need to follow, that the POLI should be tested on the biopsy with the initial tissue? Because we're waiting for the POLI results after surgeries and we're delaying adjuvant treatments. And if we're struggling for tissue, we might not ever get it, and we've got patients hanging on waiting. So if we're already, I know we're waiting for the results, but if we're acting now, should we change and do the...
In the same ways that we talked about for ovary, we should be doing all of this testing as soon as we can. So as soon as there is material available, whether that's from the Papel biopsy or in ovary it's the image-guided biopsy, if there is material that's available, then yes, we should be getting on with that testing at that point. That enables us to make those decisions in a timely manner. And I think we have to accept at the moment, POLI is new, we're just getting our way around it, we're beginning to learn about turnaround times, reliability and so on. So that's an ongoing project, but yes, absolutely, we need to push everything as far forward in the pathway as we can. If there isn't sufficient material, then we may have to wait for the hysterectomy specimen. But then you're left in the difficult situation where you could have a patient who you'd normally give adjuvant therapy to, and you're waiting for this test which might save them from having that adjuvant therapy. So that, yeah, exactly, and that's a challenge and something we're going to have to work through. But I think it's fair to say it's early days yet. Yeah.
So you're not recommending POLI as a blanket testing, right? Because BAGP has come with a flow chart where POLI is not supposed to be done on all endometrial biopsies.
So at the moment, POLI is done for where it will change.
Yeah.
It's not done out of that because of the cost and resource implication of the testing strategy.
Okay.
No, we're recommending within the context of that BAGP flowchart, which I know looks up on her slide, I didn't include, I don't know, you hinted at it, didn't you? But it is widely available. If you just Google that, it comes up.
Yeah.
And that's the criteria that we should be using.
Okay.
Outside of those, it's not going to change our practice because for various reasons we're either not going to give them any adjuvant therapy anyway, so this is not going to change that.
Thank you.
Oh, hand at the end. Amrita.
To answer, but most of the DGH radiologists do their own biopsies, the reporting radiologists.
Okay.
I don't know what happens in MFT, but even in Christie's, I know the reporting radiologists do their biopsies as well. What we wanted to ask you is whether it will help you if we send, even if we got a scanty sample, if we send a separate pot for you guys in the ovaries. We don't do endometriums, obviously, the gynecologists do them, but...
So, yeah, so much more. So, yes, the mechanism and the process that we've put in place, which I'll flick up this afternoon because I've got a slide on it, is essentially all of this is driven out of pathology. So samples go to pathology and then will be targeted over to the genomics lab for testing, and results come back to pathology and then are fed back to the clinical team. So we as individual clinicians or radiologists don't need to ever split samples and send them in two different directions. Everything we take out goes to pathology and they will then sort out where it's going from there. So I think our plea at the moment is as much material as possible, and then as we begin to understand where our failures are in the system, then we'll know whether to actually increase it in one area or not. You know, do we need to take 2 passes of Papel, for instance, to try and get as much material as possible? Or do we need an extra pass with the image-guided needle to get enough material? But it's not about splitting it. It all goes to pathology. Pathology then divides it from there.
I think one option for the endometrial would be prior to the hysterectomy, you could take another Papel or a biopsy and send that fresh, because you prefer fresh, don't you? You won't get the formalin breakdown.
Fresh definitely gives us better DNA. We are set up for fixed. Okay. We can cope with fresh, but with certainly pathways that we need to develop a bit further so that we can routinely get fresh for everything.
Okay. So possibilities, watch this space.
Yeah.
Okay, thank you very much. And I'm very glad to tell you, I think it's lunchtime. We'll reconvene. What time are we starting again, Eden? 1:15, and we'll be starting on our set of health inequalities talks. Thank you.
Thank you very much.
Is lunch just through here?